Hi everyone, myself Dr. Mariam. I'm here to guide you through today's lesson on hypertension, which is going to be both engaging and educational. Let's move forward. Definition. So, hypertension or HTN, it is also known as high blood pressure, a long-term medical condition in which the blood pressure in the arteries is persistently elevated. So, high blood pressure is when the force of blood pushing against your artery walls is consistently too high. So, this damages the arteries over time and can lead to various serious complications like heart attack and stroke, etc. Hypertension is the another word for this common condition which we call, and the SPB, that is systolic blood pressure, will be more than or equal to 140 mmHg, and DBP, that is the diastolic, will be more than or equal to 90 mmHg. So blood pressure is the measurement of the pressure or force of blood pushing against the blood vessel walls, and our reading, as I've mentioned, our BP reading, that is the blood pressure reading, has two numbers. The top number is the systolic blood pressure, which measures the pressure on our artery walls when the heart beats or contracts. The bottom number is the diastolic blood pressure. This measures the pressure on your artery walls between beats when your heart is relaxing. So this is the two numbers, that is the systolic blood pressure and diastolic blood pressure. Next is the types. So there are different types, like primary and secondary also, which we'll be discussing in the further slide. So in this, with this hypertension stage 1, hypertension stage 2, and pregnancy induced hypertension. So these are the variety or different types of hypertension we can see. In the pre-hypertension, it is the SPP will be 120 to 139 mmHg, and DBP will be 80 to 89 mmHg. And in hypertension stage 1, the SPB is 140 to 159 mmHg, and DBP will be 90 to 99 mmHg. And in hypertension stage 2, the systolic blood pressure will be more or equal to 160 mmHg, and diastolic blood pressure will be more or equal to 100 mmHg. And the last one is the pregnancy induced hypertension. So these are the different types of hypertension which we can see in this hypertension topic, or the HTN topic. Moving on to the etiology. So etiology, which we can, as I have mentioned in the previous slide, there are primary hypertension also, secondary hypertension also. So in primary hypertension, it doesn't have any single clear cause. Usually many factors come together to cause this primary hypertension. Common causes will be basically because of the unhealthy eating patterns, including a diet high in sodium, lack of physical activity, high consumption of beverages containing alcohol and all. And when coming to secondary hypertension, which has at least one distinct cause that healthcare providers can identify, the common causes of secondary hypertension, which includes certain medications, which including immunosuppressants or NSAIDs, and oral contraceptive pills, and kidney disease, obstructive sleep apnea, primary aldosteronism, or we can call this as a Conn's syndrome. Then others are recreational drug use, including the amphetamines and cocaine. Then when also we can say the cause are renal vascular diseases, which are the conditions that affect the blood flow in the kidneys, arteries and veins, and renal artery stenosis is a common example for that. And other causes are like tobacco use, including smoking, vaping, and using smokeless tobacco also. And what about genetics? So is high blood pressure is genetic, or hypertension is genetic? So according to few researchers, they believe that genes play a role in high blood pressure. If one or more of our close biological family members have high blood pressure, then where there is a chance of like have an increased risk of developing for like we also have the increased risk of developing it too. So these are the causes of and the cirrhosis of liver cirrhosis. So these are also the causes of the secondary hypertension. So there are two types: primary hypertension and secondary hypertension. So what are the causes? I have explained primary. Under this, these are things happen, and secondary, all these are the other causes of secondary hypertension. Risk factors. So risk factors that make the individual more likely to have a high blood pressure includes age, and age is as we like getting older, maybe after being over age of like above 55 years old age, then there is a chances of risk factors are more. And having a biological family member with high blood pressure or any cardiovascular disease or diabetes, or having any certain medical conditions including the CKD, that is a chronic CKD, chronic kidney disease, metabolic syndrome, obstructive sleep apnea or thyroid disorder, then having overweight, or if the individual is obese and not getting enough exercise, and because due to the stress, sedentary lifestyle, eating foods which is high in sodium, or drinking alcohol too much, or smoking or using tobacco products. So these are the risk factors that an individual can develop the condition of hypertension. Moving on to the pathophysiology. So the normal blood pressure is maintained by four mechanisms. So sympathetic nervous system activities, activities of vascular endothelium, activities of renal system, and activities of endocrine system. So in sympathetic nervous system activities, what happens is when the BP is decreasing, the activation of sympathetic nervous system will occur. The increased sympathetic nervous system activity increases the heart rate and cardiac contraction. So the increased in the heart rate and cardiac contraction produce vasoconstriction in the peripheral arterioles and promotes the release of renin from kidney. So the net effect of the sympathetic nervous system activation is to increase the arterial blood pressure by increasing the cardiac output and systemic vascular resistance. So this is what happens in the sympathetic nervous system activity. Activities of vascular endothelium. The vascular endothelium is a single layer cell layer that lines the blood vessel. So it will produce active substances and growth factors like nitric acid, endothelin, etc. So these substances are potent vasoconstrictors and causes increased blood pressure level. Coming to the activities of endocrine system, when the angiotensin 2 is stimulated in the adrenal cortex, it will secrete aldosterone. So the aldosterone will stimulate the kidneys to retain sodium and water, and thus the BP and cardiac output will get increased. So this is what happens in the pathophysiology, that is which whatever happening in the sympathetic nervous system activity, activities of vascular endothelium, activities of renal system, and activities of endocrine system. So this is the pathophysiology of hypertension. Moving on to the clinical manifestation. Usually high blood pressure causes no signs and symptoms. That's why we call this silent killer, and the patient could have a high blood pressure for years and they might not know it. When the blood pressure is 181 bar 120 mmHg or higher, the patient may experience symptoms like headaches, heart palpitations, or nosebleeds. Blood pressure this high is a hypertensive crisis, and that requires immediate medical care. And other clinical features which we can see in the patients are severe headache, blurred vision, dizziness, nausea, vomiting, papilledema, fatigue, chest pain, confusion, epistaxis, shortness of breath, irregular heartbeat. So these are the clinical features which we can see in the hypertensive patient. Diagnosis. You can diagnose the condition by asking the history of patient, their medical history, family history, medication history, or whatever, any previous surgical history or anything, you can ask about the histories and about the clinical, about the symptoms what the patient faced or is facing. You can ask those under the history. And the physical examination you can do, and you also do CBC, complete blood count, chest X-ray and ECG also have to be taken to do the diagnosis of the condition. Moving on to the management. So management, like while talking about how we can manage the hypertension, detect the hypertension in time before any serious complication arises. So hypertension means systolic will be greater than 140 mm and diastolic will be greater than 90 mm. And in case of younger patient, it will be greater than 84 mm and all. So the thing you can do is check BP regularly, routinely in every patient of high risk group. In every patient above 40 years of age, once a year you have to do BP check. And in every diabetic and obese patient you have to do. And in every case with headache, giddiness, chest pain, epistaxis, you have to check the BP. In all direct relatives of hypertensive patient, son, brother, uncle, etc., you have to do the checking the BP routinely. And while doing the management, we can divide the condition to mild hypertension, moderate hypertension, and so this is the thing we can do. Like we can divide the and severe hypertension. So in these conditions, how we can manage the hypertension. So coming to the mild hypertension, that is where the systolic will be 120, between 120 to 140, and the diastolic will be 80 to 90 mm. The first thing you have to do is salt restricted diet. Avoid extra salt and pickles. Salt in cooking may be allowed if possible. Low sodium salt should be used. And low fat diet. Avoid oil, ghee, deep fried food, that is less of saturated fats. Reduce weight if overweight by regular exercise. Regularize walking hours and sleep for 8 hours. Yoga for relaxation of mind, and daily brisk walking for 45 minutes will helpful. You can prescribe tab alprazolam 0.25 mg HS for 10 days, and also advise them to check their BP every week. If not controlled, then you can advise tab Athen 25 mg one daily, or tab Telma 20 mg OD, or that is telmisartan. So this is what you can do, prescribe to manage the mild hypertension cases. In case of moderate hypertension cases, where there is systolic blood pressure will be between 140 to 160 and diastolic will be 90 to 100 mmHg, you can start with a beta blocker or angiotensin 2 antagonist or ACE inhibitor or calcium channel blocker or alpha blocker. For example, you can advise tab atenolol 50 mg 1 to 2 daily, avoid if bronchospasm, or tab lopressor 50 to 100 mg daily. It is a beta blocker. And or you can advise tab lozaga 25 to 50 mg OD, that is losartan, or tab telma 20 to 40 mg OD, telmisartan. It is a drug of choice. Or tab envas 2.5 mg to 10 mg OD, that is a ACE inhibitor. Or capsule depin 10 mg OD to TDS, it is a nifedipine. Or you can advise tab minipress XL 2.5 to 5 mg OD. If even after all this, if it is not controlled, add a diuretic. You can advise tab hydrochlorothiazide 12.5 mg OD. It is a most antihypertensive drug, are available in combination with hydrochlorothiazide 12.5 mg. For example, Envas H, Lozacar H, Telma H, Aten H. So if there is edema or CCF, add a stronger diuretic, that is tab dietid half for 1 OD, or tab laciloctone half 1 OD, or tab Acidrex 1 OD. And we can also advise to combine two drugs if it is not controlled. If we can advise combination of two drugs, for example, beta blockers plus calcium blockers, or ACE inhibitors plus beta blocker, or calcium blocker plus ACE inhibitor, or alpha blocker plus ACE inhibitor, etc. and also advise them to stop salt intake completely, even the salt in cooking, bed rest if necessary, hospitalize, refer to a physician for advice and if investigations if above measures fail to control the BP. And also ask them to check the BP every month more frequently if fluctuating, and serum cholesterol and blood sugar level every year, x-ray, chest ECG and echo for baseline reading. So these are the most important points you have to keep in mind in case of treating the moderate hypertension. Moving on to the severe hypertension. So what are the things you have to do in case of severe hypertension? So hypertension, here severe hypertension, the size systolic will be 160 to 180 and diastolic will be 100 to 110 mmHg. And so here we can start with a combination of two drugs. For example, amlodipine plus lisinopril, tab amlo plus L 1 OD to BD. Amlodipine plus plus amlodipine plus metoprolol, that is tab stamlo beta 1 OD to BD can be advised. Or you can also advise telmisartan plus ramipril, that is tab telmisartan R 1 OD to BD. So these are the combination of drugs, combined drugs. So then also you can advise tab diter 10 mg 1 OD, it is a diuretic, and tab restil 0.25 mg HS, it is a alprazolam. So you can advise these medications. And if in case BP is above 200 mm systolic or 120 mm diastolic, give depin 10 mg sublingually, it is a nifedipine. Bed rest is advised. If not lowered within 10 to 15 minutes, repeat depin sublingual and refer to a physician. To be given in the ICU setup only, this injection label 50 mg slow IV or 2 mg per minute infusion, or labetalol, or injection esmolol 500 mg slow IV stat or NDG trip. So this also can be advised in case of severe hypertension. And also we have to advise in all the conditions like mild, moderate, severe hypertension, you all have to always advise a diet for hypertension, that is ask the patient to take a low salt diet and low fat diet. So low salt diet, that is total salt intake should not exceed 2.5 gram per day. No extra salt should be taken during meals. Use a low salt where salt is essential. Avoid salt rich foods like pickles, pappard, sauce, cheese, salted butter, etc. And take potassium rich foods like grapes, mosambi and all. Then also you can advise low fat diet, like avoid saturated oils like coconut oil, dalda, butter, ghee, cream, etc. And instead of that, use a monosaturated oils like olive oil, or polyunsaturated oils like sunflower, corn, karadi, like that is safflower oil. And also you can advise avoid all deep fried foods and skimmed milk, meat, and increase fiber intake, that is leafy vegetables, salads, fruits, pulses and legumes. Use skimmed or double toned low fat milk, and be very strict about low fat diet. So if serum cholesterol is very high or lipid profile is abnormal, or if like any heart disease associated with that, it will be very risky. So better to maintain a low fat diet. Coming to the complications of hypertension, that is coronary artery disease, a stroke, heart attack, peripheral artery disease, eye damage, vascular dementia, kidney disease, complication during pregnancy. So actually the untreated hypertension are the main causes which may lead to all these serious health problems. So these are the complications of hypertension. So now we'll discuss about the one case, an ICU case. It is an hypertensive emergency case. So let's start the case discussion. So the patient profile, the name is Mr. Ramesh Kumar, a 68-year-old male. He's had hypertension for 15 years but admits to taking medications irregularly. And he is also diabetic, which compounds vascular risk. Today he presents with symptoms that are red flags, which is severe headache, blurred vision, confusion, and breathlessness. So, what could be going wrong here with these symptoms? Maybe it is hypertensive encephalopathy, stroke, pulmonary edema, cardiac strain. So, these are the things which could be going wrong here with these symptoms. So these symptoms suggest that multiple organ system might be involved, especially the brain and heart. So we are already thinking in terms of hypertensive emergency rather than just high BP. So this is the first patient profile. Now about the vital signs. So let's break down his vital signs. His BP is extremely high at 220 per 130 mmHg, and he's very drowsy but arousable. His SpO2 is low and he's breathing fast. There is oliguria, which suggests renal hypoperfusion, and there is high respiratory delay plus low oxygen. So there is a possible pulmonary edema, and GCS is 13. That is like we worry about hypertensive encephalopathy or stroke because they are slightly drowsy also. So these are the emergency department findings of the patient. Initial clinical suspicion. So with neurological symptoms and cardiac signs, we are likely dealing with a hypertensive emergency defined by high BP with end organ damage. So it is a hypertensive emergency with neurological symptom, possible hypertensive encephalopathy or stroke, and cardiac sign is dyspnea and tachycardia. So these are the neurological symptoms and cardiac signs. So this is a hypertensive emergency defined by high BP with end organ damage. So this is the case. And about the investigation results. So the test, what are the results findings in the investigation of the patient? ECG shows LVH, left ventricular hypertrophy, that is a chronic hypertension. CT brain, no, there is no bleed, so but cerebral edema is present, so it points to encephalopathy. Chest X-ray, pulmonary congestion, fluid overload, possible LV failure, and creatinine is elevated, which suggests that acute kidney AKI due to hypertension or diabetes. Fundoscopy, grade 3 retinopathy, so it confirms the chronic damage. Troponin, it is mildly elevated, could be demand ischemia. ABG, metabolic acidosis, which indicates hypoperfusion or AKI. So these are the investigations, the findings we saw in the patient. Diagnosis. So after reading this case history and findings, diagnosis hypertensive, we can confirm this as a classic hypertensive emergency with the organ involvement, brain, kidneys, eyes, and possibly heart also. And target organ damage here is brain, that is encephalopathy, kidneys, AKI, retina, and probable cardiac strain also. So always base the diagnosis on both BP and evidence of damage, not BP alone. And the ICU admission monitoring you can do, the patient needs intensive monitoring, real-time BP, ECG, neurological status, and urine output. Urine catheter is essential to measure output accurately. So we have to advise all, we have advised these to the patient. So continuous ECG monitoring, arterial line placed for real-time BP monitoring, urinary catheterization to monitor the urine output, and neurological checks hourly. These are the ICU admission monitoring is advised. And coming to the management protocol, so immediate BP control is done. So we started with the IV labetalol 20 mg slow IV over 2 minutes, followed by 40 mg every 10 minutes. It is chosen for CNS safety, central nervous system safety, and cardiac control. Titrate dose to response. And BP goal, next BP target. So we aim to reduce MAP by 25 percentage in the first hour to avoid ischemia. And oxygen hypoxia in the oxygen support is given administration of oxygen by mask. So hypoxia was an organ or injury, so are always support with oxygen. Fluid status, avoid rehydration, overhydration. uh, Patient is at risk of pulmonary edema, so you have to maintain the euvolemia, no aggressive fluid due to risk of pulmonary edema. Monitor response, so vital signs have to be checked every 15 minutes initially. And transition to oral. Once stable, we start oral and antihypertensives here, like amlodipine and telmisartan. And that is a transition to oral drug. So once BP stabilized after 24 hours, started on oral amlodipine 5 mg plus telmisartan 40 mg. And what is a preferred IV drug in pregnancy induced hypertensive emergency? Anyone can guess this? The preferred IV drug in pregnancy induced hypertensive emergency is labetalol or hydralazine. So that is, you can like this is the labetalol or hydralazine, that is the preferred IV drug in pregnancy induced hypertensive emergency. And the management will not or doesn't need like end in ICU. So we have to advise the patient about the education, diet and stress reduction. Means the post stabilization plan also we have to advise them about the dietary changes, low salt diet, patient counseling, the importance of adherence to antihypertensive, lifestyle advice, yoga, stress management in OP setting, and a regular follow up for every 2 weeks for 2 months, then monthly. And then ask them the patient to take the prescribed drugs. And the key learning points here is hypertensive emergency is a medical crisis. It focuses on controlled, not rapid BP lowering. It is an emergency, medical emergencies treat the organs, not just the numbers. And IV drug choice depends on the target organ affected. BP must be lowered slowly and safely. Long term success is equal to education, follow up, and lifestyle. So you have to advise them. And prevention of the recurrence is as important as acute treatment. So proper education, follow up are very essential to prevent the recurrence of the hypertension. So this is the small case about ICU case in it and as a hypertensive emergency. So this comes to the end of our topic, hypertension. I hope you got the clear picture of this topic. Thank you.